Good morning, everyone. I hope you're having a good day. Today we're going to review Chapter 3 content. So if you could go onto D2L and click on Chapter 3 PowerPoint slides, you can follow along, take notes, and dig into your Chapter 3, page 44 in the book. If you haven't purchased the book yet, it is the Essentials or Resources for Personal Trainer, 5th edition through ACSM. All of your test content is coming from the book and our slides, so make sure to log in. I'm going to go ahead and share my screen. My goal is to make this fast so you are not stuck in class for way too long today. All right, so Chapter 3, we're going over anatomy and kinesiology. This is the basics of the muscles, the joints, and how they work in exercise. So we're going to stand up today a few times in practice. We'll move around a bit, and that will be a helpful tool for you to use as your own body as you learn this information. So our objectives are to overview of the anatomical structures of the muscular system and to look at the biomechanics and kinesiology of the movement, as well as look at key terms that describe body position and movement. Towards the end, you'll look over all of the joints, all of the muscles, and look at movement patterns, range of motion, common injuries for each location on the body. So two definitions that you'll need to know: biomechanics and kinesiology. These are the disciplines primarily involved with describing and understanding human movement. So both of those go hand in hand. So biomechanics is the study and cause of motion of living things. And then the kinesiology portion is the study of the mechanics of human movement. So biomechanics is essential for personal trainers because it forms the basics of documenting human motion, which is also kinematics, human motion, and understanding causes of that motion. So that's kinetics. So kinesiology is based on 3 fields of science, which includes the study of gait, how a person walks or moves, the study of posture, and body alignment. Ergonomics, sports and exercise, and activities of daily movement, as well as work. So describing joint movement and body position, you can go ahead and stand up here. An anatomical position is when your body is in just an erect state. So body is standing straight up, feet are together. Okay, upper limbs are hanging at the sides, your palms are facing forward, thumbs are away from your body, your fingers are extended. So when you start, this is your neutral position or anatomical position. So here's a picture of a person in anatomical position. You'll notice you have the sagittal plane, the frontal plane, and transverse plane. Okay, so from here, looking at those 3, the planes will dissect the body. So your frontal plane is going from front to back. So if I were working with a client, I would think that I might have 2 walls, one in front and one in the back of me. So this position might be more of like shoulder press. I'm staying in the frontal position, frontal plane. From there, sagittal, now that is where I might have flexion and extension. Maybe I'm doing bicep curls. Maybe I'm hinging at the hip, okay? And then the transverse plane is going to be on a horizontal plane. So from there, I can do any kind of twisting, any kind of ease up and twist, any kind of wood chop. So get up and practice that for a moment. Go into frontal plane, okay, coronal plane. Sagittal will bisect the sides. Okay, so you might do a forward lunge or reverse lunge in the sagittal plane, transverse, anything twisting or turning horizontally. Your center of gravity is the theoretical point that depends on your body's position. So that will change with movement. So whenever I'm standing up and my limbs are all in one line, my center of gravity is straight. Now if I go to sit down in my chair, my center of gravity is going to change. The line of gravity is an imaginary vertical line. It's going to help define proper body alignment and posture. So that's an important one when working with clients. We say ground through the feet, keep your core tight. We're trying to keep the line of gravity so that that person stays balanced. You'll see a lot of charts and tables in chapter 3. Go ahead and print that stuff out, study them. Definitions of anatomical locations and positions are here. So you'll see anterior, front of the body, posterior, anything in the back. Okay, you'll have anterior and posterior muscle groups. Okay, those might be protagonists, antagonists later on. Superficial, so located to or on the body's surface, or deep muscles. So let's say superficial might be more of the rectus abdominis, but then deep muscles might be your internal obliques. Okay. Superior, inferior, so higher or lower on the body. Medial is towards the midline. Okay, so lateral is away from the midline. And we'll dive into all of these a little bit deeper as we move on. Joint movement. It's described in terms of anatomical position. So your examples might be flexion, which would be decreasing a joint angle. That's usually moving anterior in the sagittal plane. So if my hip joint is in movement, I might do hip flexion, which might be a deadlift, and then hip extension as I stand up to finish the move. You can go ahead and practice that. Other joint movements might be abduction or adduction. So abduction of the ankle joint might also be eversion. Okay, so at that point, if this is my ankle, eversion would be, an abduction would be away from the midline. Okay, so it'd be out. If I were inversion, adduction of the ankle, I might turn more into the midline. Okay, so inversion, eversion, adduction is inversion, closer to the midline. Abduction is eversion, away from the midline. So start to practice that. I think getting up and moving is going to help you. Musculoskeletal anatomy. Now we're looking at the interaction of the bones, joints, and muscles, which determine the range of motion of a joint, specific movement that's allowed through that joint, and the amount of force that can be produced. You'll see in the skeletal system, we have the axial skeleton, which is the skull and the hyoid, okay? And then you have the appendicular skeleton, which is the remaining bones, in particular those of the upper and lower limbs and their respective girdles. So these pictures are going to help you as well. Practice, make flashcards. Skeletal system here, looking at the bony structure, you've got different pieces of the bone. Okay, your diaphysis is going to be the main portion of the long bone. The epiphysis is going to be the ends of the bones that are covered by articular cartilage. So that's your connective tissue that reduces friction and absorbs some of the shock in the synovial joints. Metaphysis is the third piece, and that's the region of the mature bone where the diaphysis joins each epiphysis. All right, bone shape. So now we're getting into different shapes of bones. Your long bones, you might think like a femur, your tibia, your ulna, that has diaphysis and a medullary canal. Your short bones are small and thick, so think your carpals, your tarsals, and your flat bones are plate-like, so think of your sternum or your ribs. You've got irregular bones that are oddly shaped, like any of your vertebrae, or your sacrum. And then you have sesamoid, which are found within the tendons and the joint capsule. So sesamoid, think sesame seed. An example of that would be your patella. So the articular system is made of bones, joints, and ligaments. Your ligaments are tough, fibrous, connective tissues that anchor the bone to bone. Joints, you have different types. So we have synarthrodial. They do not move. So let's think those are like the sutures of your skull. Okay, synarthrodial don't move. Amphithrodial, they move slightly and they're held together by ligaments. So your inferior tibiofibular joint. Diarthrodial or synovial joints are the most common type of joint in the body. And we'll get into synovial joints. You can jump onto page 51 if needed, and you'll see that the synovial joints are enclosed by a fibrous joint capsule. Okay, that capsule encloses joint activity. And synovial membrane is going to line the joint capsule, which allows synovial fluid to line on the inner surface of the capsule. Articulating surfaces of bones covered with hyaline cartilage. So figure 3.7 is going to give you a picture of your synovial joints. Classifications of joints, a little bit deeper, diving into each type, are going to be on the table 3.3. And then we'll follow up with joint actions table on 3.4. As we look at joint motions and planes of motion, closed pack is one example of a position when there is maximal congruency of the joint surfaces and maximal tautness of the joint capsule and ligament. Open pack is going to be loose. So when there is at least joint congruency and the joint capsule and ligaments are most loose. Then you dive into different movements. When open chain movement is when the distal segment of a joint moves in space. So an open chain movement. An example of that, let's say that I'm doing a bicep curl. I have a dumbbell in my arm. Open chain would be the bicep curl because the distal segment of a joint moves in space. Okay. Now a closed chained movement is where the distal point of the joint is fixed. So let's say a body weight squat. My feet are now on the floor and now I'm in a closed chained movement. Okay, so open chain, we might also think like a leg extension on a machine. Joint motions, again, as we dig a little more, look at range of motion. The degree of movement within a joint. So we always talk about decreased range of motion for a less fit individual or a less mobile individual. Decreased range of motion if a person's injured, etc. So we have active, passive, hypermobile, hypomobile. Active is the range that can be reached by voluntary movement from contraction of a skeletal muscle. Passive can be achieved by external means. Okay, so let's say there's a machine that's helping us get into that range of motion or another person helping us get into the range we need. Hypermobile are joints with excessive range of motion. Hypomobile have restricted range of motion. Joint stability, looking at ligaments, muscles, tendons, fascia, atmospheric pressure, and the bony structure. Ligaments facilitate normal movement and resist excessive movement. Facilitate normal movement and resist excessive. Muscles and tendons enhance stability, particularly when the bony structure alone contributes. Little stability. So if the bony structure alone doesn't give much stability, let's say the shoulder joint, the muscles and tendons become strong and they're able to stabilize the shoulder. Fascia contributes to joint stability. Let's say example, the IT band of the TFL. Atmospheric pressure creates greater force outside of the joint than the internal pressure exerts within the joint. So atmospheric pressure is important for aiding in joint stability. Lastly, the bone and bony structure is an important contributor to joint stability. So what type of bony structure is it? And is there limitations of extension? The muscular system is on page 56. Look over the muscle man there. You can print those out as well and know your muscle groups, especially for the activity for this week and for our practical sessions and practical tests. So there are skeletal muscle, cardiac muscle, and smooth muscle. So those are the three types of muscle tissue. Skeletal muscle is attached to bones, and that is under voluntary control. So you tell that muscle what to do. Skeletal muscles are adhered to the skeleton by tendons. So in the muscle men and in these future pages on chapter 3, you're going to see that. Bursa, well, let's go back to tendons. Tendons are dense cords of connective tissue that attach a muscle to the periosteum of the bone. Bursa are between the tendons and the bony structures that allow the tendons to slide smoothly across the bone. Here are your muscle men. They're on page 56 and 57 as well. I suggest printing these out, getting to know the muscle groups, practice them with your friends and family so that you know which muscle groups you're working when you work with clients. Classification of skeletal muscles is on 55, page 55. So we have the fiber architecture, which means they're either parallel or pinnate skeletal muscles. Parallel means the muscle fibers run in line with the pull of the muscle. So an example of that would be the biceps brachii. A pinnate is fibers run obliquely or at an angle to the line of pull. Okay, so you've got unipinnate, bipinnate, and multipinnate. Unipinnate fibers are on one side. Bipinnate is two fibers on two sides. Multipinnate is two or more attach obliquely and combine into one muscle. I'll show you some photos here in a sec. Joint actions are uniarticular, biarticular, and multiarticular. Uniarticular is a muscle that causes movement at one joint. Your example would be your brachialis, movement at one joint. So we can say bicep curl. Okay. So classification of skeletal muscles is by fiber architecture and joint action. Let's take a look at the muscles now here on figure 3.10. So you'll see that the first one, A, is strap. That is longitudinal muscles are strap-like. Okay, they're strap-like. It looks like a strap with parallel fibers. So this is your sartorius. So in the upper leg, your quadriceps femoris. Okay, then you also have fusiform, which these muscles have a parallel arrangement and are spindle shaped, tapering at each end. So there's your biceps. Okay. From there, we have quadrate muscles that are four-sided, and they're usually flat and consist of parallel fibers. So this is not included on here, but a quadrate muscle would be like your rhomboid. Okay, so the muscles right in between your shoulder blades. So those are usually four-sided and flat. Again, consist of parallel fibers. Looking over here at this multipinnate, this is your fan-shaped or triangular muscle. Okay, so your subscapularis, this is on the back. And it contains fibers that radiate from a narrow attachment to a broad attachment. Another example would be your pec major in the front. All right, so how muscles produce movement? You have levers, you have muscle actions and rolls, factors influencing muscle, force production, and movement patterns. So skeletal muscles produce force that is transferred to tendons, which in turn pull on the bones and other structures such as the skin. So your origin and insertion, attachments that move stationary, that are more stationary, are usually where the origin of that muscle is located. And the insertion is the attachment located on the bone that moves more and is located usually more distally. Okay. So my origin of my biceps brachii would be here at my shoulder, because that, when I do a bicep curl, that's the area that's more stationary, and the insertion would be down below. That's where there's more movement and more distal from my body. Specific joint anatomy on page 59. Tables 3.5 and 3.6 summarize major joint movements, muscles that produce those movements, and normal range of motion values and examples of resistance exercises for those muscles. Look at these tables when you're doing your activity assignment for this week. You'll get some helpful information. Okay, so you'll see the tables are here. Upper extremity, joints, muscles, and movements. Okay, it's going to show you different exercises. I gave you exercises in that activity, so dive in and get some answers. All right, so upper extremity. Here we're going to start getting into the different parts of the body. So first we have the shoulder complex, which is a multi-joint structure. It provides the link between the thoracic cage, okay, and the upper extremity. This shoulder is a ball and socket joint, which means it's hypermobile and not very stable. So the bones in the shoulder provide little support. The muscles, it's important to stabilize those muscles with ligaments and joint capsules. And we need to strengthen those muscles with safe movement to avoid injury. The shoulder is more likely to be injured than the hip because of its low amount of stability and high mobility. Here are the bones of your shoulder. Okay, so know the humerus here. Then you have the scapula in the back, and then you have your clavicle. And then going into ligaments here, you'll see that all of these ligaments, they attach the bones. You'll see bursa that's also involved. And if you look deeper into bursa, this table 3.13 is what a bursa looks like. So in the shoulder joint socket, you have bursa that is fluid that supports the muscle. Okay. So we're going to stand up now and practice some movements of the shoulder. So we can start by just standing up in anatomical position, feet underneath you, standing up tall. And from here, we're going to go into shoulder abduction, which is the arm is, let's say, a lateral raise. So this is ABD, and then adduction is bringing it to the midline. So abduction, adduction. Practice with me. Abduction, ABD, adduction, ADD. From here, we can go into horizontal abduction and adduction. So that would be adduction, ADD, or abduction, ABD. So adduction, close to the midline, or abduction. Circumduction and flexion and extension. So circumduction is making circles or hypermobile. Okay. Flexion would be, I'm in this position here, arm is up, and now I'm extension, extending. And then flexion. Okay. Now from there, internal and external rotation. You might see some softball, baseball players doing a lot of this. So external rotation of the shoulder and internal rotation of the shoulder. So practice with me, external rotation of the shoulder, internal rotation. Okay, so all these are movements of the shoulder or the glenohumeral joint. Now we go into movements of the scapulothoracic joint, so in the back. Okay, so you'll know starting position is neutral, shoulders nice and relaxed. And we can go into elevation, which means shoulders up to the ears, practice with me, and then depression, pulling the shoulders down. So elevation, depression, okay? Protraction would be pushing forward, winging almost. Retraction would be pulling them back. So when we teach a person how to do a back row or a pull up or a lat pull down, this type of stuff is going to be helpful. Teaching them how elevation, depression, and also scapular retraction to use the big muscle groups. Okay. D is internal rotation, so putting your arms up, and just internally rotating the shoulders. Okay, external rotation would be opening the shoulders up. I use an example of tightening a light bulb. Okay, so if I am to tighten the light bulb, I'm going to externally rotate. So here's my light bulb, tighten it and pull the shoulder down and back. If I have an overhead position, maybe a barbell overhead, I need to tighten the light bulb to pull the shoulders down and back, getting my shoulders into external rotation. Okay, and then anterior and posterior tilt would be E, so I'm tilting forward and back. Okay, go ahead and practice those. Here are muscles of the neck, shoulder, and trunk in the anterior view. This just breaks your muscle man up a little bit more. Posterior view, get to know them. Muscles of the rotator cuff are here, so this would be your anterior view. This would be your posterior view. And now we get into the elbow, which the elbow is going to be involved in a lot of daily activity and exercise. Lifting, carrying, throwing, swinging, and most upper body movement. Okay, we will review this list here, bones, ligaments, etc. Here are the bones and ligaments of the elbow joint. And movements of the elbow, go ahead and stand back up and practice with me. So in anatomical position, your arms can go, elbow can go from neutral to flexion and extension. Flexion and extension, okay. We can also go into pronation, palm down, and supination. So think I'm holding a can of soup. Pronation, supination. Here are the muscles of the arm from the back. And now we go wrist, hand, and fingers. So most activities of daily life and sports involve gripping, lifting, riding, typing, eating, throwing. So here are the bones of your wrist and hand. And here are movements of the wrist and hand. So go ahead and put your arm out. We can go into radial flexion or abduction by bringing the fingertips up. Or we can go into ulnar flexion or adduction, bringing the fingers down. Okay. Now let's put your palm into pronation. From here, the wrist can go into flexion, which means palm is facing the front. Okay. Or extension. Okay. Sorry, I am backwards. So palm is in supination. We're going to go flexion is palm to you, extension is palm away. So flexion, palm to you, extension away. Feels kind of good to move the wrist a bit. All right, muscles of the forearm are here for you to study from the anterior and posterior view. Now we're getting into the lower extremity. Okay, so we've got different movements here. Anterior view of the hip and pelvis. From there you have ligaments of the pelvis, the anterior view, and then you have the acetabellum of the hip joint. Different movement of the pelvis. This is on page 84 if you want to practice. Okay, so you're in neutral position. From there we go into rotation, so some movement side to side. Okay. From there back to neutral, and then we can go into a lateral lift of the frontal plane. Okay, so one side is up, one side is down. Think of how some people stand and rest. They might go one side, now you have one hip up, one hip low. Okay, and then you have anterior and posterior tilt of the sagittal plane. So anterior would be, my hips are more forward. Okay, posterior would be my glutes are under me. So posterior tilt. So let's say neutral, we have a bucket of water. Okay, in a neutral position, my bucket of water will not spill. But if I'm rotated anteriorly, the bucket will spill from the front. Posteriorly, the bucket will spill from the back. So go ahead and practice with me here. So we're going to go from adduction to abduction. So if you go my feet, okay, so abduction would be leg extended out to the side. Adduction is closer to the midline. ABD, add to the midline. We can do flexion and extension. So extending the leg back or flexing it forward. Okay, so back and forward or neutral. And lastly, internal and external rotation. So that's of the hip joint. Okay, so am I externally rotated, where my knees are now tracking over my toes? Or am I internally rotated, where now my knees might come in and go into valgus knee? You want to be neutral here in that position so there are no injuries. Here are the muscles of the hip and pelvis from the posterior view. Muscles of the thigh. And as we work on lower body strengthening, all those planes of motion matter and all muscle groups matter so that you have balance and the knee, hip, and ankle joints are safe. Here is your muscles of the thigh in a posterior view, lateral view, and now we get to the knee. So the knee joint is your largest in the body because it bears the load of the upper body and the trunk and is crucial for motion. It's frequently subject to overuse and traumatic injuries. Okay, at the joint, we can do flexion and extension of the knee. Here are the bones, ligaments, and menisci of the knee region. Okay, the bones would be your distal femur, okay, your proximal tibia, and the patella, or the kneecap. Looking at alignment, and when we talk about training all the muscle groups and keeping balance is important. So normal alignment, you see that the knee tracks right over the toe. Genu varum would be the knee is out over the toe, and valgum or valgus knee would be knees in. So our goal as health and fitness professionals is to help people find that neutral position and be able to maintain it. You have two major ligaments of the knee, the cruciate and collateral. And we can get back up and practice moving. You can flex and extend the knee. Okay, so as we're looking at our legs, standing up, you can flex and extend. Okay, practice flexion of the knee, extension of the knee. Bones of the ankle and foot. You'll see ligaments of the ankle and foot as well. here. From here, we can dorsiflex and plantar flex. So practice that in your chair. Put your foot out and dorsiflex, which would be toes to the shin, and plantar flex, toes down. Then you have inversion, eversion, and normal. So eversion is pinky toe up. Inversion is big toe up. Muscles of the leg are there, lower leg. Page 98 has these in your book. And now we get to the spine. So the spine plays a crucial role in functional mechanics. Okay, it's intricate, it's a multi-joint structure. It's going to link your upper body and lower body extremities. It's very important because it protects the spinal cord. It enables trunk motion in 3 planes. And it protects your internal organs of the chest, so the rib cage of the thoracic spinal region. Whenever we say enables trunk motion in 3 planes, that is again the frontal plane, sagittal plane, and transverse plane. So the spinal column contains bones, which are all of these. The vertebrae are complex of irregular bones stacked on top of each other. We have 24 total vertebrae. You have 7 in the neck region, cervical. You have 12 in the thoracic region, that's your mid-back. And you have 5 in your lumbar region or the low back. So it goes skull to sacrum. The ribs attach to the 12 thoracic vertebrae and form the thoracic cage. The sacrum and coccyx are at the lower spine and they're inferior to the 5th lumbar vertebrae. So looking here, this would be that lumbar vertebrae and then coccyx and sacrum. Here is your thoracic cage. On page 103, we will look at the different curves of the spinal column, kyphosis, lordosis, and scoliosis. This is your normal curves, neutral position. Okay, and digging in, we have different issues that might come up. So we have hyperlordosis, which means a big anterior tilt. The water is falling out of the bucket from the front. Okay, you might have super tight hips, pulling the low back. His glutes might be underactive. There could be a lot of issues going on there that you would, as a trainer or physical therapist, help that person find balance. Hyperkyphosis is now the upper back is rounding. The abs are probably very weak, and this area could be chest very tight, pulling the low back or the upper back into rounding. And then you have an issue called scoliosis. Okay, so this is in the frontal plane and it's a lateral deviation. Okay. Lordosis and kyphosis are in the sagittal plane, so it's going to make that person stand odd in the sagittal plane. Ligaments. You have longitudinal ligaments, anterior and posterior longitudinal ligaments, and the ligamentum flavum are your main supporting ligaments in the spinal column. Okay, your interspeneous and supraspinaous ligaments are attached to adjacent posterior structures. Ligaments and discs of your lumbar spine are here. They're also on page 103. Intervertebral discs, you have 3 types. They're located between the vertebral bodies and constitute about 20 to 30% of the height of the vertebral column. All three of these are composed of water, collagen, and proteoglycans. Your joints, you have one intervertebral joint, and you have 4 facet joints. Okay. Lumbar allow for flexion, extension, and restrict axial rotations. So you can't really twist in the lumbar region, the lower back. Cervical and thoracic are angled to accommodate axial rotation. Okay, so you can move your head and neck, practice that, get some nice movement, and then move your cervical spine or thoracic spine. The spine is capable of motion in all planes. To the extent of motion, it varies on the region, like just discussed. Okay, and let's get up and practice some. So standing up, you have flexion and extension. So flexion and extension. Okay, you also have lateral flexion and extension. Do it on both sides. And then you have rotation. Here is compound trunk extension, which basically means the trunk motion in the sagittal plane during normal activities, such as lifting and bending, require this compound movement of the lumbar spine, pelvis, and hip joints. And that action of movement is called compound trunk extension. Almost there. Muscles, you have cervical and lumbar. Okay, so the spine and trunk muscles exist in pairs, one on each side of the body. Anterior muscles flex the spine, posterior muscles extend it. Here are deep muscles of the back to get to know. And lastly, injuries. So cervical injuries, common ones are whiplash, maybe in a car crash. Okay, whiplash, any kind of traumatic neck injury means medical emergency. So those are usually very traumatic issues. The cervical region is your most mobile region of the spine, and the small cervical muscles are responsible for supporting the head. So it is vulnerable to stability issues and injury. Lumbar is where we have low back pain. That's one of the leading causes of disability. It affects 60 to 80% of the general population at least once in their lifetime. And with all of this, we want to think about restorative exercise because it's designed to improve the structural integrity of the lower trunk. That's commonly used for treatment of low back pain. Okay, that is chapter 3. If you have any questions, please let me know.